We will now hear from 3 other scholars about with expertise from related fields, reflecting on the book and on the more generally on the topic of our diagnosis. And we will start with Amanda Hylland Spjeldnæs, who is an MD, PhD student at the University of Oslo, working on antimicrobial resistance. So Amanda, please.
My name is Amanda Hylland Spjeldnæs, and I'm a 5th-year medical student at the University of Oslo. And I'm also a research school student, which means that I'm working part-time on a research project that hopefully eventually will turn into my PhD. And I really enjoyed reading this book. And in this talk, I will talk about the topics of this book in the context of antibiotics use. Because as you know, antibiotics use leads to antibiotic resistance, which means that the antibiotics that we use today will stop working in the future. And in Scandinavian countries, we see a decrease in the use of antibiotics, but this trend is not the same worldwide. And globally, the antibiotics use has increased a lot the past 20 years. So in this talk, I will try to connect local and global perspectives on antibiotics use, because antibiotic resistance is not a local problem. And as we saw with the COVID pandemic, pathogens travel across borders, and antibiotic resistance in one place can quickly spread around the globe. So the title of my talk is Resistance Requires Revolution. And that is because my argument is that we need a structural approach to understand antibiotics use. And this approach is in contrast to the most common efforts to reduce antibiotics use in the world today, which is individual behavioral change, including the so-called stewardship interventions. For example, awareness campaigns that encourage people to not use antibiotics for viral infections. And interventions that target the individual behavior, they require that the individual has the possibility to change behavior and to use less antibiotics. And my argument in this talk is that the individual often does not have the possibility to change health behavior, and structural barriers and not only individual choice lead to the overuse of antibiotics. So in this talk, I will use my research school project as a case study. And in 2021 and 22, I spent 6 months on a fieldwork in Shatila refugee camp in Beirut in Lebanon. And the project is interdisciplinary, so it's connecting elements from medicine and from anthropology. And my method was an anthropological fieldwork, and I did participant observation in camp pharmacies, and also interviews with people in the camp and some group workshops with people from the camp. And before I continue, I just need to say a few things about Shatila, about this setting. So this camp was established for Palestinian refugees in 1949. And today it is very overcrowded because it hosts both Palestinians and also Syrian refugees. And Palestinians and Syrians, they live very difficult lives in Lebanon today. So they have very limited rights and are, for example, banned from working in a long list of professions. And many cannot travel freely around in Lebanon. And now there's also a devastating economic crisis in the country, which affects the refugees. And as you can see from these pictures, the environment in the camp is very poor, and streets are full of mud and dirt and garbage and electricity cables, and the houses are small and humid. And access to healthcare is poor in the camp. And in theory, the refugees have access to healthcare from organizations like the United Nations, but these services are very overcrowded. And to be honest, I didn't meet one single person claimed that they received quality healthcare in the camp. So instead, people went to the pharmacies, which I will come back to. And I quickly learned that people in the camp, they use a lot of antibiotics, and mostly for other things than bacterial infections. So people use antibiotics, for example, for headaches, for sleeplessness, for tiredness, or for general illness feeling in the body. So a question that I looked into in my fieldwork was, why do people in Shatila use so much antibiotics? And an important aspect of this is the access to antibiotics is huge in the camp. And the access is huge because of politics. So as I mentioned, the healthcare from organizations in the camp is very overcrowded, but the camp is full of private pharmacies, like you can see in these pictures. And the pharmacies, they mainly sell smuggled Syrian medicines, which are a lot cheaper than regular medicines in Lebanon. And these Syrian medicines, they end up in Shatila due to the political instability, both in Syria and in Lebanon. And these medicines, they are not approved by Lebanese authorities, but they are sold freely in the camp because Lebanese authorities do not regulate life in the camp. And that's partly because of historical reasons, like the Sabra Shatila massacre in 1982. So this picture illustrates just how available antibiotics is in the camp. And I took this picture from behind the counter of a candy store. And as you can see, you can buy cheap single pills of different medicines. And you can buy the yellow and red pills there. They're amoxicillin. And buying antibiotics in the camp require no prescription and is one of the most accessible forms of care in the camp. So antibiotics is also one of the cheapest forms of care in the camp. And a camp doctor imitated his patients and said, if I have money, I can go to the best doctor, order labs, order culture, I can do it. I have money with me. But if I don't have money, I want to go to the pharmacy and take anything without doctor. So I saw this, people skipping the doctor, going straight to the pharmacy many times. And an example is from this picture that I took in a family home in the camp. And they had this ceftriaxone injection at home, which is an antibiotic. And if someone in the family got sick, they brought this bottle to the pharmacy so that the pharmacy worker couldn't give the injection. And they skipped seeing the doctor first to save money. And people also tried antibiotics when ill because they needed to recover quickly. Because they couldn't be away from work and lose the day's income, which they needed to provide for their families, because there are no sick leaves in Shatila. So the chance that antibiotics might make you feel better when ill made it worth trying. And another reason why people in the camp use so much antibiotics is that selling antibiotics is an important source of income for people in the camp. So people from all over Lebanon actually visit the camp to buy medicines because the cheap Syrian medicines are not available in regular Lebanese pharmacies. So Alia, a doctor who works in the camp, said that if I don't write antibiotics, I will lose patients. Patients are cheap, they will go to another doctor. And the reason why Alia prescribes antibiotics is often to keep the paying patient on her list. And Alia repeated, I know this is wrong, 25 times during our hour-long conversation where she talked about her prescribing practices. And she also mentioned that it has to be like this in the camp because it's all about money in the camp. And if she loses her patients, she will not be able to care for her own family. So this illustrates that awareness campaigns aimed at people like Alia to prescribe less antibiotics would not work because Alia already knows that she's prescribing too much antibiotics, but the structure of healthcare and life in the camp pushes Alia to sell antibiotics for other reasons than only bacterial infections. And using antibiotics also make people feel empowered and independent. And throughout history, people in the camp have been let down and abandoned by both the Lebanese authorities and also the world's society several times. And life in the camp today is worse than ever, over 70 years after it was established. So a young Palestinian told me that you have to care for yourself in the camp because no one cares. And I am my own doctor seems to be a saying in the camp. And I heard this repeatedly from several camp residents when they had shared with me their self-taught knowledge about health and medicines and antibiotics. And also, I cannot remember one visit to a family home that did not have a home pharmacy like the one you see in this picture. And people often had several bags of medicines in case themselves, a friend, or a family member got sick. And injecting antibiotics at home was also not uncommon. So by having antibiotics at home, camp residents had a tool to protect themselves from the camp conditions, and self-medicating with antibiotics gave the camp residents a feeling of control over their lives and power to take care of themselves in an otherwise helpless situation, where no one else cares about you. So in Shatila, suffering due to different life situations is often medicalized to a condition that can be treated with antibiotics. And just think of the people who use antibiotics for sleeplessness and just for general tiredness in their bodies. And underlying factors that can lead to these conditions could be poverty, discrimination, and inequality. And that is not easily treated. So in Shatila, being labeled as a patient who needs antibiotics concretizes the suffering to something that can be treated with a cheap pill. And camp residents, they cannot really do much to get more civil rights in Lebanon, but they can try antibiotics. And antibiotics also give people a language to explain and express their need for relief. And antibiotics give hope to people who live in a setting where there is very little hope in general because of the discriminating politics and the poverty. So these examples from Shatila show how antibiotics use is a consequence of structural factors, and using antibiotics also when there is no bacterial infection is not only an individual choice. And antibiotics has functions in people's lives that fill gaps that exist because of structural constraints. So people in Shatila suffer because of political discrimination, war, poverty, international aid politics, and using antibiotics is a way of dealing with this difficult situation. And the medical anthropologist Claire Chandler introduced antibiotics as infrastructure, and this metaphor is useful to discuss how antibiotics use is structurally conditioned. So antibiotics as infrastructure means that the society is dependent on antibiotics for people's lives to continue as usual. And since we have access to efficient antibiotics, we can construct societies as if bacterial infections were almost non-existent. And antibiotics conceal poverty and they conceal poor living conditions by compensating for the things that do not work in society. And let me give some examples of how antibiotics is infrastructure in Shatila. So because of the access to antibiotics, extremely poor living conditions, overcrowded houses, poor sanitary conditions, and contaminated drinking water is not as big an issue as it could be because bacterial infections can be treated with antibiotics. And the poor access to healthcare services is not a total disaster in the camp because people kind of accept using antibiotics instead. So maybe camp residents do not suffer as much as they would be without antibiotics. And if antibiotics disappeared in the camp, because of resistance, for example, the poor structural conditions in the camp would become even more visible. So antibiotics is also infrastructure in Norway, even though we have way better living conditions than in Shatila. So for example, Norwegian hospitals can have relatively small infection wards and carry out treatments such as transplantation, cytostatic drugs, and surgery without a high risk of infection. And employers can expect their employees not to need a sick leave due to bacterial infections. And general practitioners can see maybe 50 patients in a day because if they rapidly prescribe an antibiotic to half of them, these patients will be happy and many of them will also recover. And farmers can put hundreds of pigs in the same enclosure without risking the spread of bacteria. And in some other countries, farmers can also use antibiotics as a growth promoting supplement to produce larger pieces of meat. So in this way, antibiotics enable fundamental values in the modern world, such as standardization, modernization, urbanization, and globalization. So antibiotics use has led to unnatural expectations to the speed of action, and humans and animals have become a more reliable labor force since we not so often need to be off work when you have antibiotics as a quick fix for disease. And this in turn enables standardization and streamlining in society more generally, which results in a more predictable economic growth. And predictability and the high speed induce modernization by enabling development to happen faster. And antibiotics also make it possible for the labor force to be concentrated in overcrowded cities where the sanitary condition might not be good enough because infections can easily be cured anyways. And we can also travel across the globe without the fear of bacterial infections and without the fear of spreading or introducing new bacteria to new societies, because the diseases can easily be treated anyways. So only when resistance is widespread will the infrastructure that antibiotics is holding up collapse. So if or when antibiotics stop working, for example, in Norway, infection wards at hospitals can be very overcrowded, and more patients might suffer from infection complications after surgery. And also the number of sick leaves from simple bacterial infections, such as urinary tract infections, might increase, and productivity will decrease. And also there can be long queues for general practitioner appointments. Meat can become more expensive and scarce. And also there can be, or we might have to have travel restrictions like during COVID. So to succeed in reducing the overuse of antibiotics and limiting antibacterial resistance, we need new strategies that take into account the importance of structural conditions for antibiotics use, both in low and high income settings. So understanding antibiotics use as structurally conditioned and as infrastructure make the challenge greater, because it requires a lot more political will and resources to implement structural changes in society than to do an awareness campaign about hand washing. So we need to target the upstream causes that lead to antibiotics use, and maybe reducing antibiotic resistance requires a revolution. So the structural measures, they need to be tailored to the specific context, which requires interdisciplinary work, connecting knowledge from medicine, from social sciences, and other fields. And in Norway, structural changes could, for example, be less ambitious expectations for production efficiency and stricter regulations for antibiotics use in animals. And in Shatila, measures could, for example, be reducing poverty, improving living conditions, and giving the refugees civil rights in Lebanon. But that being said, this does not mean that we should not do anything less than structural change. And small-scale antibiotic interventions can also contribute to limiting the spread of antibacterial resistance. But we need to acknowledge that reducing antibiotics use also requires structural changes and maybe even a revolution. So I've written about some of these topics in an essay in the Journal of the Norwegian Medical Association. And here's some of the literature that I've used for this talk. Thank you.